ready to go.
Awesome. Okay, well, hi everyone and welcome to the second round of the Pharmacy Huddles. Today we're going to start a topic, the pain pathway. So this is one of two lectures or educational sessions that I'll be giving around this topic. Today we'll be focusing on the analgesics, just a couple of them because obviously it would be quite a bit to go through in the time schedule. So to start off with, pain, as we know, is very multi-dimensional. So you've got all these pathways, the gate control, and then you've got certain patient characteristics like catastrophizing, hyperalgesia, which also come into play, as well as psychological, situational and emotional factors. And all of these contribute to the pain sensation on an individual basis. You've also got procedural pain expectations as well. So trying to work all of that out, you're looking at multimodal management. So different pain relievers used at different times during the pain process that work together to give better pain outcomes. So the analgesics, paracetamol, NSAIDs, you've got your opioids, atypical opioids now, and also, of course, importantly, your non-drug options as well. So these are, for example, surgery or icing, things like that. Your adjuvants to pain control, you've got your antidepressants and your anticonvulsants, which are generally used in more of a neuropathic pain setting, which we'll be going into a little bit more in the next presentation. So paracetamol, you guys are pretty aware of where it gets used. So it's good for mild acute pain and can be opioid sparing as well. They still don't 100% understand how paracetamol works, but it is around the endocannabinoid system. So in terms of the dosing of paracetamol with children's doses, I believe here we base it on weight up to 50 kilograms, but if the child is obese, then we do use ideal weight. But I believe we've got some standards for that. The NSAIDs, so these have work on COX-1 and COX-2. So it's COX-1, the inhibition, where we've got the gastric side effects potentially and the antiplatelet effects. And the inhibition of COX-2 is your anti-inflammatory and analgesic actions. So there can be a reduction in glomerular filtration rate and renal blood flow, and that occurs with both COX-1 and COX-2. You do have ones with selectivity, and more we're seeing the more selective COX-2 inhibitors being used. There's little difference in efficacy between the products at appropriate doses, and your main concerns are GI events, risks of CV events and renal impairment. So you're looking at patient history and risk factors when prescribing. Quite often they're co-prescribed with proton pump inhibitors in GI risk patient groups, and celecoxib is generally preferred. There can be no response in about 60% of patients, in which case maybe try another one. But of course the prescriber will look at all of that. So in terms of the side effects, we're pretty familiar with all of these because we've been working with them for so many years. But just always keep in mind there is a risk of renal impairment after surgery, and that risk is increased by concurrent medications such as diuretics and blood volume loss and dehydration. So this is just some general information about the non-steroid anti-inflammatory drugs as well. In the elderly, there is an increased risk of adverse effects, in particular heart failure, GI, and renal impairment, so just bear in mind. In terms of the counselling, this is basically straight from the AMH, and we're looking at signs of internal bleeding, possibly less so with COX-2 inhibitors. And then we always recommend the non-selective NSAIDs that you take them with food. So that's like your diclofenac and ibuprofen. So just a couple of interesting ones, celecoxib, so that one is selective for COX-2. In terms of pain, the recommended dose 400 milligrams on the first day, and then 200 milligrams once or twice daily as needed up to 5 days, which we see quite a lot in our discharge scripts. and it's the preferred one for GI risk patients. You're looking at about 200 milligrams a day with proton pump inhibitors and has decreased renal risk. Meloxicam, also a more selective anti-inflammatory, but the COX-2 selectivity of meloxicam is dose dependent. So if you're going at 7.5 milligrams, it's more COX-2 selective, but when you're getting up to 15 milligrams, you lose that selectivity. Okay. Opioids. So opioid analgesics act on opioid receptors. They act mainly at the mu opioid receptors in the CNS, so reducing transmission of the pain impulse, modulating the descending inhibitory pathways from the brain. The affinity of individual opioid analgesics for receptors does vary, which is why I've got those differences in strengths. And they're indicated for acute or chronic pain, although their role in chronic non-cancer pain causes a lot of problems, and their role is continuously being questioned. So long-term use as well can cause immune suppression and opioid-induced hyperalgesia. We all know what those patients are when they come in their chronic pain patients. They're a little bit more difficult to manage in terms of their pain therapies and things like that. Okay, so in terms of precautions, we'd be aware pretty well of most of these. So you're looking at the sedation, seizure risk, things like that. So always bear that in mind. In terms of a few other ones, the dose requirement decreases progressively with age generally. There is an increased risk of adverse effects as well, including cognitive impairment, sedation, respiratory depression and falls. So use a generally lower initial dose and then titrate to effect. And then in terms of renal use, avoid use of codeine and pethidine and lower doses of hydromorphone, morphine and tramadol, just with caution. So, or alternately, use an opioid such as oxycodone or tapentadol or fentanyl with dose adjustments. Alrighty. Side effects, we're again pretty aware of all of the potential side effects to watch out for, so that's just here for general information. In terms of the counselling, I guess for you guys in theatre, you wouldn't do it so much, but when the patients are going home and when they're being counselled on discharge medications, some patients or their family are very apprehensive or downright against taking opioid pain relief, so it's important to acknowledge their concerns and then highlight the benefits of good pain control and address any issues or fears. Alternatively, we've got some patients that think as required is a dosing schedule. So our counselling and information that we provide should enable them to make informed choices and hopefully minimise any adverse effects. So codeine, we're pretty familiar with most of this information as well, but interestingly, sports med codeine is contraindicated in children 17 and under in our protocols. So just be aware of that. And codeine is a prodrug, so it's metabolised to morphine by CYP2D6. People with normal codeine metabolism, they'll metabolize 30 milligrams of codeine to approximately 3 milligrams of morphine. But some people are unlikely to obtain pain relief due to their genetic lack of CYP2D6. So you're looking at about 6 to 10% of Caucasians and 1 to 2% of Asians. Some people are alternatively ultra-rapid metabolizers and may achieve higher morphine concentrations, which increases their risk of toxicity. So there's always that until we start routinely genetic testing. Tramadol, a mu opioid receptor agonist and serotonin reuptake inhibitor. It's considered to be an atypical opioid for that reason. There's a reduced risk of constipation, respiratory depression and abuse, but a higher seizure risk than other typical opioids. So the opioid component of activity requires an active metabolite, M1. So there's also CYP2D6 recommendations in terms of the polymorphisms for those patient groups as well. At SportsMed, we tend to not use it in children under 12 years. Try and avoid in people over 75. Adverse effects. We're pretty familiar with a lot of these, particularly with serotonin syndrome and things like that, to watch out for concurrent administration of other serotonergic drugs. That being said, serotonin syndrome is quite rare, so I wouldn't even know if we've had many reported cases here, or it's usually quite a low incidence, so that's good. In terms of morphine, just wanted to point out in terms of the intrathecal morphine about that delayed onset and prolonged duration. So, you know, the 24-hour monitoring is always done in terms of looking at your patient for 24 hours after that. So in sports med guidelines, we prefer to use non-narcotics as add-ons to these patients and avoid sedatives in the first 24 hours ideally. Alrighty. Equianalgesic dosing. So once established a protocol, if it's not working, then this can be useful for the prescribers to work out what to try alternatively. Comparative tables of approximate doses, so that's just from the AMH. So in sports med guidelines, so these are just a couple of things. You're looking at reassessing your patient pain after each intervention. So within 20 minutes IV, 60 minutes IM, subcut and oral, and 15 to 60 minutes non-pharmacological. Obviously in recovery, you guys do it a lot more frequently than that, especially when you're using your fentanyl and things like that. So the pain protocols generally in recovery area only. And then you're looking at ceasing it when the patient is comfortable or when side effects occur. There's a flow chart in the procedures. And then in terms of pain management, in our procedures, there's the principles of intervention and patient education, which gives a good little list of things that we should be giving to our patients when they discharge in terms of their pain management plans. So considerations after surgery, chronic pain is a possible outcome. There are some predictive factors which include pre-operative pain, repeat surgery, a surgical approach with a risk of nerve damage, acute and severe post-operative pain, which is pretty much encompassing all of our patients, radiation, chemotherapy, and a variety of psychological and depressive symptoms as well. So opioids are the first-line treatment for severe acute pain. A key principle is to titrate the dose against the desired effect, which is pain relief, and to minimise the unwanted effects. So regular dosing should be expected for the acute pain phase. Education and planning around the patient is key. So thank you for that. That was just part one today. And thanks for all your support down at the pharmacy. Remember to come in for your flu jab.